Can you hear that now?
Hi, everybody. My name is Vaidya. I'm an assistant professor in medicine at the University of Southern California in Los Angeles. I want to welcome all of you to the ACC Fellows Bootcamp 2021. For all the new fellows that are starting out here in their fellowship in California, welcome, and you'll realize that's a great place to train. And if there's anything I can do to help your experience be better, please reach out. I'm an advanced heart failure and transplant cardiologist, and today I'm going to talk to you about acute heart failure management. So let's start off with the case. So it's 11 p.m. on your first call as a cardiology fellow. You're called down to the emergency room where you see a 65-year-old female who's presenting with ischemic cardiomyopathy, EF of 20% that's known from prior. She has symptoms of dyspnea at rest that her vitals are as shown below. She's tachycardic, hypotensive, she's decapitated with the oxygen saturation 85% on the. So now what do you do next? Obviously, the first thing you do when you go into the room after speaking with the patient is doing your physical exam. How can this information help you? You're then going to treat the patient for acute decompensated heart failure. And we'll go over the things that you need to know to treat a patient effectively in the acute setting. And then you're going to follow up your treatment. If things look worse, what do you do? How do you react to that? And what do you do when the dust settles? So your initial thing is you're examining the patient. So how does this information help you? So your clinical findings allow catheterization of hemodynamic profiles. So you guys might have seen this table before, and it was popularized by Lynn Warner-Stevenson. And it shows basically on one axis signs of congestion or volume overload, and on the other axis signs of hypoperfusion. So some of those things are kind of noted above. And things like evidence of congestion are things like orthopnea, elevated JVP, an S3 auscultation, edema on exam, things like that. Now I'll tell you whether the patient is wet or dry. Signs of hypoperfusion include things like a narrow pulse pressure, cool extremities, altered mental status, etc., and evidence of end organ dysfunction. Now I'll tell you whether the patient is warm or cool. Okay, and how does that help you? So it can help you not only in terms of treatment about what you want to do next, but also it has prognostic value. Your initial assessment in the emergency room not only guides treatment, as I said, but also offers an early assessment of what the prognosis is at a year and a half. So the patients that initially presented as cold and wet have nearly a 2.5 times worse mortality than the people that are warm and dry on presentation. So now that you kind of have your physical exam under your belt, you have some basic information about how the patient looks in terms of their hemodynamic profile and what the prognosis could be in the near and long term. You want to start treating the patient for acute heart failure. So what do? You give them a Lasix dose that's either the IV equivalent of their PO dose. So if they're on 40 PO daily of Lasix, you put them on 40 IV to start, or you can just give them a higher dose, either 80 IV, BID, or whatnot. You can give them morphine for symptom relief and reduction of the preload, and also their sympathetic drive, nitrates, oxygen, and position them to upright with their leg dangling to help further reduce preload. So we'll start going through some of these things, but the first and most important thing is to get some diuretics on board. So how do we think about diuretics? So the dose trial, which was published in the New England Journal of Medicine in 2011, looked at several strategies that are common in heart failure patients. So looked at low dose versus high dose, and then looked at bolus versus continuous. The key points here is there's a 2x2 factorial design, but the takeaways was that high dose was more likely to leave you bulimic at 48 hours. High dose was associated with greater net fluid loss, weight loss, relief from dyspnea. High dose was also more likely to be seen with a small but statistically significant increase in creatinine by 0.3. Bolus was more likely to see higher doses of diuretics at 48 hours, with no difference in other endpoints. So, with that being said, the takeaway from this is that you can safely choose a high dose continuous infusion, but at the minimum, making sure that you're hitting patients with the higher dose diuretics. But diuretics don't come without any negative effects. So they are associated with activation of the renin-angiotensin-aldosterone system, and initial worsening in your hemodynamics, but also associated with worsening mortality. So this is something showing an increase in plasma renin activity before diuretic or after diuretic, as opposed to before. And then these are the kind of initial worsening of your hemodynamics. You have an increase in your heart rate, your mean arterial pressure, SPR, and even your wedge pressure after an IV diuretic. But also you see an increase in mortality with higher doses of diuretics, which kind of can indicate worsened disease state and heart failure. So we talked a lot about diuretics and vasodilators, but how do we compare those, and how can vasodilators help attenuate some of these effects of diuretics? So this is a study that was published many years ago, over 20 years ago, of 110 advanced heart failure patients that presented with decompensated heart failure, and they were given your LMNOP up front, your Lasix, morphine, your oxygen, and your positioning, but they were just randomized to either receive Lasix at very high doses, at 80 milligrams IV every 15 minutes, or nitrates, 3 milligrams IV 2 to 5 minutes. That's in addition to the initial 40 milligrams IV that everybody's getting. And then this protocol was followed until patient saturations improved or the blood pressure worsened less than 90 or decreased by 30%. You can see here, very small study, but with very few kind of outcomes, but there was less mechanical ventilation, myocardial infarctions, and adverse events that were statistically significant with the addition of nitrates to some level of diuretic therapy. So what's the bottom line? Diuretics are essential for the management of volume overload, but have the deleterious effects. So choosing high dose continuous infusions really results in the best outcome in terms of rapid volume removal. But nitrates and vasodilators can help offset some of the hemodynamic and neurohormonal derangements that are seen with diuretics. And as you guys will see from practice, nitrates are important, but an underused tool in the treatment of acute heart failure. So let's go back to our patient. So it's 11:30, and you're in your best case scenario here. Your heart rate is decreased with your initial Lasix, morphine, nitrates, oxygen, and positioning of the patient. Your blood pressure is stabilized, respiratory rate, and your oxygen saturation will all improve. The patient has made pretty good urine, 500 cc's in about half an hour, with creatinine that seems pretty stable for patients at baseline. You tell the emergency room and the admitting residents that the patient's okay to go to a regular telemetry report. But you guys will see, and have probably already seen in your careers, that things can also get worse, and so reassessing response to therapy is really important. So walking through a case of a patient that doesn't look better, more tachycardic, more hypertensive, and respiratory status is much worse. Patient made very little urine output to Lasix, and the creatinine has gone up pretty rapidly. What do you do next? So some of your options that we'll kind of discuss is you put them on a Lasix strip, that we discussed in the dose trial. You add tolazone, you place a PA catheter, you put the patient on IV nitroglycerin, you add butylamine, you offer ventilatory support, or you call your kidney colleagues for assistance with hemodialysis or ultrafiltration. So take a moment to think about these and what you would do next. We'll go through each one of them. Before we go through kind of the options that are available to you, let's kind of take a pause and think about some physiology. So this patient is demonstrating cardiogenic shock. They have signs of hypoperfusion with an increase in their creatinine, with hypotension, etc., and a narrow pulse pressure. So the important hemodynamic equation here to keep in mind is that your mean arterial pressure, which is your assessment of perfusion, is equivalent to your cardiac output times your systemic vascular resistance. So your body is built to regulate itself to maintain homeostasis. So at all costs, it wants to maintain perfusion or mean arterial pressure. So as your heart, as you can kind of see, the top is suffering with the decreased cardiac output, that will lead to a reduction in your MAP. The goal of your body is to maintain perfusion, so it's going to increase SVR. Unfortunately, increasing SVR will increase your afterload, which will further decrease your cardiac output, which will reduce your MAP, and so on and so forth. So really, this becomes a vicious cycle where people can kind of spiral very quickly in terms of this cycle of cardiogenic shock. So the key here is to break this cycle. So you want to target something that can increase cardiac output while also decreasing SVR. So it's important to understand that diuretics in this setting won't work until your cardiac output increases. And so there's a kind of an old saying in heart failure that the addition of inotropes and vasodilators in this setting will help you warm up before you dry out. So let's talk a little bit about IV inotropes, and first starting with the guidelines. So the ACC/AHA guidelines from 2013 for the class 1 indication for IV inotrope use in patients with cardiogenic shock that are awaiting definitive therapy. It's a class 2A indication for patients that are awaiting transplant or mechanical circulatory support, durable support like LVAD. Class 3 indications, it's important to know your class 1s and your class 3s. So class 3, the things that you should never do is treat patients with acute decompensated heart failure with inotropes in the absence of hypertension or hyperperfusion. So importantly, they must show signs of shock before you introduce IV inotropes. Let's go a little bit deeper in them. I think these are something that you guys will all be using quite often. So it's important to just understand what targets are available to you as you're thinking about what your options are. So in terms of your adrenergic receptors, you think about your alpha-1, alpha-2, beta-1, and beta-2. So your alpha-1s are located in your vascular smooth muscle and are responsible with activation for increasing your SVR through systemic vasoconstriction. Your alpha-2 will also found in your vascular smooth muscle, but also in your central nervous system. So they cause vasodilation, but also sedation, which you'll see with Precedex, which is an agent that you guys will use in the ICUs. Beta-1 are seen in cardiac muscle and increased chronotropy and inotropy, and also contractility, increasing cardiac output. So with minimal vasoconstriction. Beta-2 is also found in your vascular smooth muscle, causing vasodilation, reduced SVR. Dopamine and acetylcholine receptors are found both on vascular smooth muscle for dopamine, but more in the splanchnic beds and the renal beds, and can cause that vasodilation in those beds. Acetylcholine are parasympathetic receptors that have chronotropic effects on the heart. So you think about atropine, which is an antagonist, it can stimulate or accelerate AV nodal conduction. Phosphodiesterase 3 inhibitors can increase contractility in the setting of milrinone and improve diastolic relaxation, so lucidity. These are also found on cardiac muscle and vascular smooth muscle. Vasopressin B1 and B2 receptors are found both. B1 is found in the periphery and in vascular smooth muscle and causes vasoconstriction. And B2 receptors are found in the renal collecting system, which can cause water resorption. So it's important to understand those receptors because each of the agents that we'll kind of use have differential effects on all of these receptors. We're going to talk about inopressors first, the first being epinephrine. So epinephrine binds to alpha-1, beta-1, and beta-2. It's important to understand that it's beta predominant lower doses, so you're going to get more of an inotropic or chronotropic effect in these doses, whereas it's alpha predominant in higher doses, so it's going to have more of a pressure effect. The dosing range is kind of seen there, and special scenarios to consider it in are critical aortic stenosis, post-cardiotomy shock or shock after cardiac surgery, RV failure, anaphylaxis, and near embolism. But it's important to remember that prolonged high doses of epinephrine can cause cardiac toxicity and lactic acetylation. Levofed and norepinephrine has the same receptor activity. It's a little bit less beta activity than epi, and particularly alpha predominant at high doses. At higher doses, similar to epinephrine. But it's important to know that it's a little bit more of a pressor rather than an inopressor than epi. So epi is going to have a little bit more bang through butt in terms of inotropic action. So the dosing range, as you can kind of see here, and special scenarios to consider it for. So by the surviving sepsis guidelines, septic shock is the first line agent, but also cardiogenic shock. And we'll kind of go over the trial note for that, where it's also a first line agent in the setting of cardiogenic shock and hypertension, which was kind of validated in the SOAP2 trial, which we'll go over in a moment. Then also vasoplegia after cardiac surgery. An important pearl to remember is that if your norepinephrine requirements are increasing, two things you can't miss are you have to go back to the drawing board and make sure that you have a good assessment of the patient's volume status, that you're not treating hypovolemic shock, for example, with higher doses of pressors, but also the pH is adequate. pH is less than about 7.2. You start having diminished or no response to catecholamines, so endogenous and exogenous. So, making sure that you're treating the underlying causes of the acidosis in that setting, or treating them with bicarbonate so they can have some receptor activity. Dopamine is kind of the dirtiest of the drugs, and that it has multiple receptors that it works across. It works on alpha-1, beta-1, beta-2, but also dopamine receptors. It binds dopamine receptors at low doses, promoting vasodilation. These are doses like 0.5 to 3. So promoting vasodilation in some of those splendic renal beds. And it binds adrenergic doses, adrenergic receptors at higher doses due to inotropy and vasoconstriction. So at 3 to 10, it has some weak beta-1 agonism that promotes norepinephrine release. So that's when you're going to get a little bit of inotropic action. In at doses greater than 10, you see kind of higher and higher doses, higher and higher effect of alpha-1 agonism, so more pure vasoconstriction. So my bias here is that there's very few kinds of scenarios to really consider it for. Oftentimes it's kind of found as your first bag premix, often a code card, but it's important to understand that running it peripherally, dopamine is not without risk. Extravasation can also lead to the same signs of tissue necrosis. So kind of beware of peripheral use. But since it's such a dirty drug, I kind of find a few scenarios where I really like to use it. The one trial you need to know in terms of the comparison of dopamine and norepinephrine is the SOAP2, which I mentioned before. So it looked at nearly 1,700 patients of many different types of shock. And it found that across all comers that there's more arrhythmic events among patients treated with dopamine. But importantly for our talk is that a subgroup analysis showed that dopamine as compared with norepinephrine was associated with an increased rate of death at 28 days among the 280 patients with cardiogenic shock. So, a decent sized sample of patients with cardiogenic shock had higher arrhythmic concerns as well as death. So that's led to its kind of adoption as the norepinephrine adoption as kind of the first line agent for both cardiogenic and septic shock in the setting of hypotension. So those were our kind of inopressors. So these are kind of pure vasopressors, phenylephrine and vasopressors. We won't go into much detail on those, but just so you know. And then in terms of inodilators, isopropyranol, which is mostly kind of used as a chronotropic agent, but you guys will be using much of is dobutamine and noradine, is kind of pure inodilators. So what about dobutamine? So receptors that it binds to is beta 1 and beta 2 predominantly. In really high doses can have a little bit of alpha 1 agonism. And so it has preferential beta 1 agonism, which is your inotropic agent, but it does have some beta 2 effects, which will give you some vasodilation. The dosing range is 2 to 40, but it's very important to remember that the doses of 40 plus dobutamine are only seen in stress testing, and really doses of above 7.5 to 10 really start having less inotropic effect as opposed to the chronotropic and alpha 1 effect. So when you guys are kind of rounding the CCU and taking care of patients that are in dobutamine in your clinical practice, 7.5 is usually as high as I go before kind of reaching for different agents or potentially mechanical support. And then special scenarios to consider it. Obviously, acute heart failure is what we're talking about today, but also, as I said, stress testing, things like ischemic stress testing, but also viability testing and determination of kind of aortic stenosis severity and the setting of low flow, low gradient aortic stenosis. So some pearls. So tolerance develops after just a few days of therapy. So either increasing the dose of the agent might be necessary or switching agents entirely. And also kind of the downside of inotropes is ventricular arrhythmias, which can occur at any dose. Milrinone is a phosphodiesterase 3 inhibitor, and inhibition of this increases intracellular cyclic AMP, which leads to enhanced contractility, but also vascular muscle relaxation and vasodilation, particularly in the pulmonary vasculature. So other properties are that it's a relatively long half-life and renally eliminated. So the dosing range is, I don't really go above 0.5 or 0.6, but that's the kind of dosing range that you see. Important to understand that you have to renally adjust the patients with significant renal dysfunction. And special scenarios to consider it are acute heart failure and RV failure, which it's particularly powerful for, given its effects in lowering pulmonary vascular resistance through that vascular smooth muscle relaxation. So they do it through the pulmonary treatment. So what is the evidence for IV inotropes? So there's a few trials that I kind of put up here. So Optum HF basically showed that in heart failure with no need for inotropes, there was more hypotension in atrial arrhythmias, but no difference in death pre-hospitalization. We already talked about the SOAP2 trial, but in the ROSE AHF trial, in patients with heart failure hospitalization, there's no difference in urine volume, renal function, or clinical outcomes. So the takeaway is that there's no benefit in wet and warm patients, and but there are indications for IV inotropes, such as cardiogenic shock. But like I said, not in routine decompensated kind of warm and wet heart failure. So unresolved issues is when to kind of best use vasodilators versus kind of going to an inodilator, such as dobutamine or milrinone, and which inotrope to kind of use first, which is best, milrinone or dobutamine. So other kind of principles of shock management kind of more broadly, just to kind of go through it quickly, is be sure your patient is actually hypertensive. Go measure the blood pressure yourself. Second is just understand why your patient is hypertensive. So it's good to kind of construct a differential and kind of going through your types of shock that are kind of I summarized in the table on your right, and really kind of construct a model for your patient's physiology. So you understand what you're treating so that you can target the physiology underlying that patient's shock. And then using the knowledge that we just kind of went over from the receptors in those specific targets, you want to match your vasoactive agents to the patient's need and where that evidence lies. And then lastly, just appreciate that drugs may not be enough. Critical care cardiology really integrates pharmacologic and mechanical interventions whenever your medical interventions have really kind of reached its limit. Okay, moving on to kind of some other things that we were kind of discussing with our patient example is pulmonary artery catheterization. So what do the guidelines tell us about this? So this is also known as a SWAN catheter, SWAN GAN. So The guidelines tell us that it's a class 1 indication for patients in respiratory distress with impaired perfusion plus unclear intracardiac flowing pressure. It's a class 3 indication in normotensive patients with acute decapitated heart failure and congestion with symptomatic response to diuretics and vasodilators. So again, in patients that are kind of warm and wet and responding to therapy, swans are not beneficial. In patients that are kind of unclear in terms of what is going on, but having signs of hypoperfusion, then it is kind of of benefit. And then the class 2As are kind of expansion of the people with unclear volume status, worsening renal function, hypotension, need for IV isotopes with patients that you're considering for transplant or MCS for kind of the 2A indications. So what are the trials for this? So the SCAPE trial showed that there's no difference in mortality, rehospitalization, quality of life in 6 months, but increase in adverse events, infections, and pulmonary artery calcium. And then meta-analysis of 13 different trials of 5,000 patients showed there's no difference in mortality or length of stay, but increased use of IV isotopes and vasodilators in the pulmonary artery group, catheter group. So what's the bottom line here? So patients do no worse with a pulmonary artery catheter, but also no better. So the routine use in kind of acute decapitated heart failure patients is not really warranted. If clinically indicated, there's no reason not to use a PA catheter. And some kind of important indications for patients that are volume overloaded with either hypotension or renal dysfunction, really where the information can help you and is not clear by kind of assessing the patient's bedside. So don't be scared to use it, but don't use it in every patient that rolls in with acute heart failure. Non-invasive ventilation. So the guidelines kind of mentioned this kind of in early iterations, and the principal basically said that putting patients on non-invasive ventilation, such as BiPAP, positive pressure, reduces preload, increases oxygenation, increases cardiac output. There's several trials that basically show that it reduces mortality and intubation rates, but no difference in kind of mortality in some smaller studies. So basically, you may reduce the need for intubation and mortality, a low risk of harm in using this, and it's really probably underused all in all in acute pulmonary edema. So what about ultrafiltration or kind of removal of fluid through kind of dialysis? So AHN guidelines give it a class 2B. So it could be used in patients with refractory congestion that are not responding to medical therapy. So it basically just removes salt and water very quickly. And there's things like CHF solutions and various kind of commercial systems, the kind of picture on the right here, that can remove these large amounts of fluid without the use of a dialysis catheter. It can usually be done through like a PICC line or something similar that each system kind of has associated with. So the takeaway here is that you have greater fluid loss, but no really kind of change in outcomes, and sometimes higher creatinine in some of these studies. So bottom line is it's an option for patients who are hemodynamically stable with volume overload, diuretic resistance, and renal impairment. But the caveat is that you need to kind of have one of these specialized systems and experienced nurses that can actually do it. And it doesn't require a dialysis catheter always. It requires some sort of access catheter. That creates some issues in terms of risk and infection. So let's go back to our worst case scenario and kind of decide which of some of these kind of solutions we talked about would be pertinent in this case. So our patient, again, is tachycardic, hypotensive with worse respiratory distress, and little change to your initial interventions of diuretics and vasodilator therapy, with worsening end organ function as noted by the creatinine. What do you do next? So here are your options that we initially presented. So we'll kind of go through them one by one and use kind of what we have learned kind of through this process. So LASIK strip does not normally work. We're adding Diaril, which is a thiazide diuretic, because of the principle that we talked about up front, which is that you need to warm up kind of with the use of inotropes and or vasodilators before you dry out. So before you start, your body really starts kind of responding to those high dose diuretics, that you really need to start getting perfusion to the kidneys, etc. Placing a PA catheter, it's not wrong, but you wouldn't want to wait to start treatment before getting your PA catheter. It can take a while to get that in sometimes. IV nitroglycerin, also not wrong, but if the patient's already hypertensive, you're going to have to be really cautious in using that. So adding dobutamine, as we talked about, to warm them up and dry them out before you dry them out is indicated. And ventilatory support and non-invasive ventilation, such as BiPAP, would be indicated. Calling renal for HD or ultrafiltration, you can do that, but you want to see kind of how you respond first then to inotropes before you go that route. So you've really kind of turned your worst case scenario into a success story with kind of the use of inotropes and non-invasive ventilation. So the patient is less tachycardic, their blood pressure and pulse pressure have improved, the respiratory rate has improved, and they're sounding much better initially on BiPAP and then decreased back to nasal cannula. They made a lot of urine over the next several hours, then their creatinine has improved back to baseline. So now you've fixed your patient, so congratulations, you can feel good about your call night, but the work for the patient doesn't end there. Whenever you kind of are treating an acute heart failure patient, you got to figure out what to do when the dust settles. So that involves kind of figuring out what underlying causes, and then figure out how you can help them in the long term. So in terms of figuring out the cause, here's a kind of a helpful mnemonic called failure. The first being kind of whether they forgot taking their medications, whether they're diuretics or guideline-directed medical therapy, whether things like arrhythmia or anemia could cause an exacerbation, things like ischemia, infections, dietary indiscretion or stress, whether there's things like thyrotoxicosis, or they might be pregnant, that can be causing more strain on their heart, and then things like that will cause exacerbation with renal failure, rheumatic or valvular disease, or pulmonary embolism. So now thinking about hospitalization, so you were seeing this patient, you really turned them into a success story, but realizing that the hospitalization is sometimes your most important time to intervene. So patients can go for many years, going from class 1 to class 3 in terms of their NYHA class, but then they can kind of decline very quickly in the order of days to months with very significant symptoms. And often this falling off the cliff, as we say, kind of happens in the setting of a heart failure kind of admission. That can kind of be the first sign. And it's important to think about that, all patients that are kind of coming in with heart failure, about whether they need to be referred to centers that specialize in advanced heart failure therapies. So it's important, as we kind of just talked about, that hospitalizations really signify that your heart failure is progressing and gives you a chance to really intervene. And with each hospitalization, there's kind of myocardial and renal damage that can contribute to progressive organ dysfunction. And as the disease progresses, there's greater levels of care and complexity, cost and follow-up that are needed. So you can kind of see here this kind of schematic that with each hospitalization that's kind of denoted by these like valleys, that they might need monitoring devices, and the addition of ICDs and CRTs, kind of remote monitoring, and then LVADs. And if they keep going without those things, potentially significant morbidity or mortality. But the rates of readmissions and what that means is really impactful to your patients. So the readmission rate for 30-day readmission rate in heart failure patients is about 22%, but there's a mortality of about 12% after hospitalization for heart failure within 30 days. that should be pretty alarming to all of you. So, and approximately 50% of patients hospitalized for heart failure are readmitted within 6 months. So heart failure rehospitalizations are common, they're associated with mortality, and that they happen, once they happen the first time, they happen repeatedly. And this kind of further hammers on the point. So the hospitalizations are frequent and the outcomes decline with each subsequent hospitalization. And the median number of hospitalizations is 3, and then more than 80% are hospitalized at least once. But whenever you're seeing a patient and you're about to discharge them from the hospital after their 4th hospitalization, and if you look over here, that they're leaving the hospital with a median survival of 6 months. So really a poor kind of survival, and it gives you an opportunity to really make sure you're doing what's best for them in terms of reporting them on to advanced heart failure specialists if that's the need. So the ACC saw that many patients weren't getting referred on quickly, and so they created this kind of mnemonic for the patients, for you guys help the patients that need help. And this mnemonic kind of goes through these 9 clinical risk factors: the need for IV inotropes, significant symptoms or persistently elevated brain BNPs, natriuretic peptides, evidence of organ dysfunction, like renal or liver dysfunction, low EFs, less than 35%, presence of defibrillator shocks, and importantly, hospitalization, even more than one is a reason to kind of trigger the thought about referring to advanced heart failure specialists. Edema despite escalating diuretics, so diuretics are going up and up and up, and it's really kind of the poor prognostic indicator, which we talked about early in the lecture. Low blood pressure and high heart rate is really telling you that the patient is optimally compensated with their own physiology, and they can't really take much perturbation from that, and that's the prognosis, of course. They really maximally compensate on their own. And then if you're down titrating guideline-directed medical therapy because of hypertension or because of renal dysfunction, that really should be a sign to you to send the patient on to heart failure specialists who can offer them things like heart transplant or durable mechanical circulatory support devices that give them survivals that are significantly improved from that. So shifting gears a little bit in terms of using hospitalizations as a time to intervene for advanced heart failure referral. It's also a time to think about making sure that they're on proper guideline-directed medical therapy. So it's important when patients are coming in for heart failure exacerbation that are symptomatic. It is recommended that guideline-directed therapies such as beta blockers, ACE, ARBs, or Entresto be continued in the absence of any hemodynamic instability or contraindications. If they don't have renal failure, they're hemodynamically okay, should continue with medication. And the reason is that we have a long way to go in offering patients guideline-directed therapies. You can see here the patients that are on the green, eligible and untreated. There's significant way to go that we need to go. Nearly 64% of patients are not on aldosterone antagonists, 20% aren't on ACE, ARBs, or Entresto, about 15% on beta blockers. So those are a large proportion of patients that are not getting the therapies that they need. So they're not getting them at all. And then on the graph on the right shows that they're not getting the doses that they need. So, less than 20% and less than 30% of patients are at goal doses of ACE inhibitors, ARBs, and less than 30% are getting the goal-directed doses of beta blockers. But it's important to realize that you have an opportunity to really impact this, because patients on guideline-directed medical therapy and discharge have improved outcomes. So when patients are started or continued on them, as seen on the green and blue kind of graphs here, they significantly improve one-year mortality rates. So simply continuing your patients on it, or starting them prior to discharge, helps them have much improved survival, nearly absolute 13%, all 13%. That's pretty huge in the book of heart failure. So to summarize our last minute here, so the pathophysiology of heart failure is, initially beneficial mechanisms that ultimately become maladaptive. So kind of adjusting our therapies based on our kind of knowledge of pathophysiologic mechanisms. So your clinical manifestation, how you kind of examine them in the emergency room, really offer insight into not only how you're going to treat them in the acute setting, but also into their prognosis. Treatment-wise, there's not a lot of evidence, as you kind of noted, for many of these therapies, but there's really some promising therapies that may be underused in the acute setting. Starting and or maintaining guideline-directed medical therapy is critical in the acute setting. So use that opportunity for patients when they come into the hospital as an opportunity for you to intervene to really impact their lives and their survival. And then lastly, hospitalization is really a high-risk marker and signifies an important time to intervene or refer for advanced therapy consideration. So really give patients a chance to really have a new life if they're a candidate by referring them to advanced therapies, either in the outpatient or inpatient setting. So that kind of concludes my talk. I appreciate you guys taking the time to listen to it. Some final words of wisdom here to leave you with, but it's important that you guys really think about kind of how complex these acute heart failure patients are, and that these kind of tried and true methods to really treat them. It's been a pleasure talking to you guys. Please reach out if any questions that come up. I look forward to speaking with you guys during the live Q&A.
All right, everybody, let's go back to our prior slide here. Fantastic talk, and here we are, so we can see everybody. All right, so now we're moving on to the live Q&A portion of it, and we have a couple of questions in the chat box. And the first one is asking, of course, we have Dr. Vaidya here with us, which is very exciting. And the first question is asking, in what scenario would be best to start norepinephrine and then give dobutamine on cardiogenic shock? Is there a threshold of systolic blood pressures?
Yeah, no, it's a great question. And I think it's important to as we kind of talked about in that lecture, to realize that norepinephrine is kind of your first line for cardiogenic shock with evidence of hypotension with hypoperfusion, so true shock. And so that is kind of when I would think about it. I don't think about it in terms of a specific systolic goal or a MAP goal. Generally, kind of prior studies, largely in sepsis, looked at MAPs of greater than 65 as kind of being what's necessary to kind of perfuse necessary organs. Although typically in heart failure, we're much more comfortable with lower systolic and MAP goals. So generally, what I do is if somebody's in shock, worsening renal function, worsening urine output, elevated LFTs or lactate, or mentation, has diminished. I start levofed for kind of a MAP goal of 65, and then once things have kind of stayed, with or without kind of a pure inotrope or an inodilator, and then kind of working the levofed down once you've kind of reached adequate perfusion to kind of a goal MAP that maintains that. So you can kind of work it down, say to a MAP of 60, sometimes even 55, etc. So that's how I kind of do it. So I think if people are showing signs of end organ dysfunction, that kind of tells you that they don't have a necessary MAP and they need something, more of a inopressor to get their blood pressure up.
Great, thanks so much. So our second question is asking about what clinical scenarios would we come across where we should be thinking about using nitroglycerin IV drip?
Yeah, what sort of situations? Yeah, so I think nitroglycerin IV is kind of a venodilator primarily. It obviously has some arterial vasodilatory effects as well. I'm thinking about it in kind of situations, patients that are in cardiogenic shock in the setting of potentially MIs, where they're having symptomatic chest pain, et cetera. Nitroglycerin is going to be great for that purpose. If they're significantly volume overloaded, and kind of even in the setting of kind of warm and wet, and they're on BiPAP and they're just not looking so hot, and you want to acutely decrease their preload, putting them on nitroglycerin, either IV or you can put nitropase. If you need to give them something quickly, even do sublingual, is all helpful things. So I think nitrates are really kind of powerful. I don't think you always need to give it IV. And generally when I'm kind of reaching for an IV agent, I'm thinking about kind of needing more arterial vasodilation as well. So those are things that you can use kind of nitroprusside in, where you're going to have more arterial and venodilation. So we have a kind of an unloading protocol for our hospital, where our medical unloading protocol, where if you put somebody on nitroprusside, you can do it even for 15 or 30 minutes and see if kind of unloading them from a veno and vasodilatory perspective will kind of improve their hemodynamics, et cetera. So I like nitroprusside in that setting. I think nitroglycerin's good, and quite honestly probably used more often because people are more comfortable with it, but you just kind of miss that ability to get kind of adequate arterial vasodilation.
Fantastic. Our next question has to do with the usage of milrinone and dobutamine. I know you discussed this a little bit as well, and it is a little bit unresolved into which is better, but what are some ways to decide when to use one over another in a patient?
That's great. And that's kind of like, kind of heart failure 101 is kind of this constant debate between dobutamine and milrinone. So the things that I think about is somebody's in, kind of cardiogenic shock and you need to start something quickly. Dobutamine is kind of your first agent that I reach for. And that's because it has kind of a short onset of action and a short half-life, right? So if you want to just get something started right away, dobutamine is kind of a better agent. And that's kind of why it's utilized in stress testing, is because it's kind of easy on, easy off. Milrinone, on the other hand, is a longer onset of action and a longer half-life. So you're not going to get kind of an immediate effect for several hours whenever you start milrinone. So it's not probably your best agent if people are kind of crumping in front of you. You kind of want to start dobutamine kind of more urgently. Milrinone's great though. I generally try to transition most of my patients to milrinone if I'm sending them home with home inotropes. If they're kind of using more chronic inotropes or they're in the hospital awaiting transplant or something, I try to transition them to milrinone. It's kind of more so for practical reasons. When people go home with milrinone, it's not uncommon for them to either run out of their bag of inotrope or for them their PICC line to come out or whatever, and that'll at least give them they'll have milrinone in their system for several hours so they can get to a hospital and ER and get kind of hooked back up, etc. So that's kind of on the home milrinone side. The other kind of theoretical benefits that I think makes sense is you probably get less tachyphylaxis with milrinone than you do with dobutamine because of the constant kind of adrenergic stimulation with dobutamine, causing kind of downregulation of those receptors. So I think milrinone for that reason, kind of for me, is kind of more of a chronic inotrope, and dobutamine is kind of better as an initial inotrope. Similarly, if people are having issues with kind of ventricular arrhythmias or arrhythmias of any kind, dobutamine is kind of easier to shut off because of what we kind of discussed before. And then the kind of issues with kind of arrhythmias, I think they both have them. So to me, it's a little bit of a wash. So I kind of think about it more in terms of practical things rather than kind of strong evidence pointing me in one direction for kind of clinical benefit.
Great, thank you. So our next question is about goal-directed medical therapy. There was a slide on the use of beta blockers, ACE ARBs, aldosterone antagonists. And the question is really about when trying to optimize a patient, is it best to try to get the patient on all of those medications, maybe on low doses, versus you try to really, optimize your dose on one before you add the other? What is it really to optimize the patient?
Yeah, great question. And this has kind of been, a hot topic in the heart failure literature. If you're on Twitter or med Twitter, if you will, this is like something that Dr. Fonero at UCLA kind of posted a ton about. So, and they actually just posted kind of the ACC just posted kind of an update talking about a little bit about different approaches to kind of doing this. So generally, the key is to get these patients on a beta blocker and a RAS inhibitor as fast as possible, and then up titrate them quickly. My practice, honestly, is to start doses of all of them in the hospital if I can. So if I have kind of a new heart failure patient that has adequate blood pressure that I'm seeing in the hospital, I'll start them on Entresto, Coreg, honestly right away. And then on day 2, if their blood pressure is kind of holding, I put aldactone and dapagliflozin on right after that, because those are kind of more blood pressure, minimal effect to kind of neutral. So I kind of put them on baby dose. I put them on DAPA and aldactone right away, and those are all kind of one dose kind of fits all. And then when I see them in their first outpatient visit, I start kind of going up quickly on the beta blocker, and then the Entresto. So over the course of 6 as soon as 6 to 8 weeks, you can kind of be at goal doses if people have kind of adequate blood pressure and are doing okay. And people that are a little bit more tenuous, you have to go a little bit slower, check more frequent labs, assess their symptoms again kind of quite frequently. So that's generally my practice. Is I start a little bit of all of them, and then I titrate them up quickly if patients are able to tolerate. In terms of what the guidelines say, it's effectively kind of what they say is to get them on some dose of at least a RAS inhibitor and a beta blocker prior to discharge.
Fantastic. Next question, you answered a little bit in the last one, but it had to do in regards to your thoughts on SGLT2 inhibitors. And what are your thoughts on this?
Yeah, I think it's the 4th pillar. I think the data has been outstanding for it, and I think future iterations of the guidelines will reflect it. The AHA, in terms of their hospital quality standards, has already added SGLT2 inhibitors to what they are going to start assessing hospitals for adhering to. So the kind of writings on the wall that SGLT2 inhibitors are not only the evidence is good for, but kind of the professional societies, governing bodies, et cetera, and insurance companies, importantly for our patients, are starting to reflect that practice that they really should be kind of used in patients that kind of qualify. And then one kind of plug that I would say, just kind of to the previous question, is that the data is really kind of astounding for how much of an impact we can make on in a hospitalization for getting patients on the right meds. So, nearly 13% absolute risk reduction by just getting patients on an ACE and a beta blocker prior to discharge. And that's not even that's without an aldactone and SGLT2 inhibitors. So the effects are kind of growing for getting the patient. So I would even advocate for keeping the patient in the hospital, another day or 2 if you have to really get them dry on a stable dose of diuretics and on at least some doses of guideline-directed medical therapy. You're really doing them a favor in the end, and the system for quite honestly.
Okay, I think we only have time for one more question. So this one is about more advanced options. Your patients coming in for recurrent hospitalizations for acute decompensated heart failure. So what are the kind of the signs for you to say, I need to start thinking about an LVAD or transplant?
Yeah, no, great question. There's one slide that I kind of had on there that it goes over this mnemonic called "I need help." It was kind of developed by the ACC and AHA as kind of an easy tool for all of us to use as we kind of assess patients for that. So big picture. And maybe if I come back next year, I can give you kind of a talk on how I think about evaluating patients for advanced therapies in terms of timing. But there's kind of clinical risk factors and kind of identified in I need help, things like necessity for IV inotropes, which are kind of the easy things, but just symptoms. The worst patient's symptoms are NYHA class, et cetera. They have they have kind of much worse outcomes. Persistently elevated BNP, pro BNPs greater than 1100 are associated with kind of worse mortality. And then kind of just going through them and thinking about patients that are intolerant to guideline directed therapy. If you're seeing a patient in your kind of fellows clinic and you started them on Entresto, they're really not tolerating it, or they've been tolerating it for a year or two, and you're noticing that they're getting more symptomatic and their blood pressure is kind of more tenuous, or their kidney function. Those are people that despite all kind of attempts at medical therapy are not doing well. And then one kind of key one that is kind of included in that mnemonic is just hospitalizations. And we talked about that for a little bit during that talk. Is just hospitalizations are really a critical time to intervene. For each hospitalization, you have increasing mortality. So it's really a good time if you're noticing patients are coming in once, twice, a third time. We work out of a county hospital, so we see this all the time. And those are really good opportunities to be like, hey, even though this patient's feeling better, ready to go home to their family, their prognosis is really poor. And then once you refer them to a kind of advanced heart failure center, we can kind of fully assess those clinical risk factors, get ancillary data, with kind of further imaging, cardiopulmonary exercise testing, and then further kind of cardiac catheterization. So it's kind of the short answer to kind of a large topic, but it's a great one to kind of segment into getting patients the appropriate care they need.
Fantastic. Well, thank you very much, Dr. Vaidya, for an excellent talk and for the Q&A and answering all our questions. We really appreciate it. And for those of you listening, thank you very much for joining us. We will be posting this. This is recorded, and we'll be posting this on our website, the California ACC website, as well as the YouTube channel that Stacy had mentioned earlier. So if you want to rewatch it or give it to some of your friends, there's ways to get it.
And as far as for next week's session, we're going to have Dr. Jason Hoff from Loma Linda University, and he'll be talking to us about Cath basics. So hopefully you guys can join us as well.
Thank
See
you
you then.